So our learning objectives for Chapter 2 would be, first, explain how TRM and CRM conceptualize trauma and resilience. Then, we will differentiate between trauma, stress, and PTSD. You will be able to identify categories of trauma: acute, chronic, complex, developmental. Describe autonomic nervous system dysregulation in plain terms. Then, preview TRM skills that promote regulation and resilience. Now, we've learned a lot about TRM and CRM. Let's discuss how you can build a treatment protocol by conceptualizing a case using TRM and CRM. Starting with the trauma resiliency model, TRM. Again, remember TRM is a mind-body toolkit that helps us understand trauma through the nervous system. Thus, instead of viewing trauma symptoms as personal flaws or weaknesses, TRM reframes them as normal biological responses that got stuck. Therefore, when we think about working with our clients, we apply these tenets by practicing skills that bring awareness to body sensations, such as helping your client notice their heartbeat, breathing, or muscle tension, enabling people to guide their nervous system back toward balance gently. The goal isn't to erase the trauma, but to restore regulation so that thoughts and emotions can flow more clearly. When working with the community resiliency model, CRM takes these same ideas out of the therapy room and puts them into everyday life. It introduces the 6 wellness skills discussed last week that anyone can learn and use. Examples again include tools for calming, grounding, and reconnecting with a sense of safety. The beauty of CRM is its accessibility. It's designed so non-clinicians, teachers, parents, and community leaders can share it. Using simple, everyday language, CRM helps groups and communities build resilience together. Main ideas to remember for both models. Both TRM and CRM highlight that paying attention to present moment body sensations, for example, feeling your feet on the floor, noticing your breath, is a powerful way to support regulation. Instead of being hijacked by overwhelming memories or stress, people can learn to come back to their resilient zone. We help our clients restore balance to their lives despite the trauma. Let's make some comparisons between trauma versus stress versus PTSD. First, let us look at stress. Stress occurs when life makes demands on us, such as exams, deadlines, or arguments. It usually consumes our resources, but once the challenge is overcome, recovery is expected. Stress is uncomfortable, but it's a regular part of life. Then there is trauma. Trauma is different. It overwhelms our ability to cope in the moment and often leaves a residue in the body, like lingering images, sensations, or impulses. Even after the event is over, the nervous system may not fully reset, and this dysregulation can persist. Now let's discuss post-traumatic stress disorder, or PTSD. PTSD is a clinical diagnosis listed in the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision, also known as DSM-5-TR. It has specific criteria including intrusive memories, avoidance, changes in mood, and hyperarousal. Not everyone who experiences trauma develops PTSD, but some do. Here are the categories of trauma. There is acute, which is a single incident such as a crash or an assault. Next is chronic. This is a repeated, ongoing issue, for example, abuse or community violence. Then there is complex, which is seen as multiple, often interpersonal events and disruptions. We also consider developmental, which might include early life adversity during sensitive periods. Additionally, We consider whether an event is a single incident versus cumulative and historical collective trauma. So what do we mean by big T and small t trauma? According to Miller-Harris, the concept of big T versus small t trauma is a heuristic, a teaching shortcut that helps us discuss different kinds of experiences. In terms of big T, trauma usually refers to so-called life-threatening events such as accidents, assaults, natural disasters, or combat. These are moments when survival feels directly at risk. Regarding small t trauma points to non-life-threatening but still overwhelming experiences such as repeated criticism, workplace bullying, or ongoing stress in relationships. Important cautions we have to consider. Small t events can accumulate and lead to just as much nervous system dysregulation as a single big T event. Think death by 1,000 cuts. Remember, trauma is subjective. Two people can live through the same event, yet one might recover quickly while another's nervous system becomes overwhelmed. An example of this can be the death of a loved one. A family member may be devastated by the death of a family member, but a close friend, although grieving, may experience it differently. The difference isn't weakness, it's how each body responds in the moment. A significant takeaway from this concept is that the big T/small t distinction is helpful for teaching, but it should never be used to minimize someone's lived experience. Impact matters more than the label. Now moving on to the autonomic nervous system, ANS. Through Miller-Harris thinking, our autonomic nervous system is like the body's autopilot. It keeps us alive by regulating heart rate, breathing, and energy levels without us having to think about it. Miller-Harris explains it in terms of 3 zones. 1. Sympathetic, high zone. When danger is sensed, the sympathetic system revs up. The heart races, breathing becomes shallow, and the body prepares for fight or flight. This is survival mode, alert, fast, and ready to move. 2. Parasympathetic, low zone. If stress is too much or escape feels impossible, the system may slam the brakes. The result? Shutdown, numbness, or collapse. It's the body's way of conserving energy and playing dead when overwhelmed. 3. Resilient zone, Euro-K zone. This is the sweet spot. In the resilient zone, you can think clearly, feel your emotions without being flooded, and act flexibly. Life has a natural rhythm. You can handle challenges without getting stuck in overdrive, high zone, or shutdown, low zone. Thus, the goal isn't to avoid the high or low zones altogether. That's impossible. Instead, it's to expand time in the resilient zone and learn ways back there when life knocks us off balance. Let's talk about the sympathetic nervous system, our body's way to use survival responses and completion. The sympathetic nervous system is like the body's accelerator pedal. When a threat shows up, it immediately mobilizes energy for survival responses. Fight, muscles tense, jaw clenches, anger or aggression rises. Flight, heart races, breath quickens, body wants to run. Freeze, onset, hyper alert, body bracing, waiting for the next move. This system is fast and automatic. It doesn't ask permission, it just acts to keep you alive. But here's the catch. If those survival responses don't get to finish, for example, you couldn't fight back or run away, the energy can get stuck in the body. This may look like constant tension, racing thoughts, restlessness, or being easily startled. Miller-Harris's completion idea is about giving the nervous system safe opportunities to finish what it started. For example, gently noticing and allowing small movements, breaths, or sensations can help discharge that stuck energy. Therefore, the sympathetic system's job is to protect you. When its responses are interrupted, TRM skills help the body complete the download so balance and calm can return. Signs of dysregulation. Millicaris explains that when the nervous system is knocked out of its resilient zone, the Euro-K zone, we can shift into patterns of dysregulation, being too high or too low for balance. High zone, sympathetic activation, feeling on edge, irritable, anxious, racing thoughts, fast heartbeat, tense muscles, hard to relax or focus. Low zone, parasympathetic shutdown, feeling numb, disconnected, or foggy, low energy or heaviness in the body, wanting to withdraw or shut down. Pendulation. This occurs when individuals oscillate between high and low zones. That back and forth is typical, but it can be exhausting. So, the goal isn't to avoid all stress, but to learn skills that bring the nervous system back into the resilient zone, where thinking, feeling, and acting happen with more clarity and balance. We must always view trauma through context and culture when working with people. Trauma doesn't happen in a vacuum. It's always shaped by the context in which it occurs and the culture of the people experiencing it. With that said, context matters. The same event can feel very different depending on the situation, available resources, and support. For example, losing a job may be less overwhelming if a strong safety net exists, but deeply destabilizing if there are no supports. And of course, culture is essential. Cultural beliefs, traditions, and history shape how people understand trauma and resilience. Practices like storytelling, ritual, or community gatherings may provide powerful protection and healing. Collective and historical trauma. Millicaris reminds us that trauma can be passed down or shared across groups, such as intergenerational trauma, racial trauma, or historical oppression. These experiences impact the nervous system and community resilience. Consequently, effective trauma-informed care must be culturally responsive, recognizing that healing is not one-size-fits-all, but deeply connected to people's lived realities, identities, and community strengths. Now, Millicaris explains that whether someone develops trauma symptoms or grows stronger after adversity depends on the mix of risk and protective factors in their life. First, risk factors. These are conditions that make trauma harder to cope with. Examples include repeated exposure to violence, lack of social support, poverty, or earlier experiences of adversity. The more risks, the more the nervous system can be pushed toward dysregulation. Secondly, the protective factors. These are buffers that help people recover and adapt. Examples include caring relationships, supportive communities, cultural traditions, meaning-making practices, and skills like grounding or mindfulness. Protective factors don't erase risk, but they make recovery more possible. Last but not least, resilience. Resilience isn't a personality trait. It's a capacity that can grow over time. With sufficient protection and support, people can adapt even after experiencing difficult events. TRM/CRM skills are designed to strengthen resilience by teaching the nervous system how to return to a state of balance. Understand, risk makes people more vulnerable. Protection offers support, and resilience is the flexible capacity that grows when the two are in balance. Finally, we'll look at the ethical and practical implications. Your textbook emphasizes that working with trauma isn't just about techniques. It also involves responsibility and care. This is probably the cornerstone to most theories. The following is considered standard across many professional organizations. Prioritize safety and stabilization before diving into deep memories. It's vital to help clients or communities feel safe and grounded. Pushing too fast can cause re-traumatization. Pace is paramount. Trauma work should be done slowly and in small steps. Titration. This allows the nervous system to handle the experience without becoming overwhelmed. Informed consent. People deserve to understand what mind-body methods involve and agree to participate in them. Respecting choice is part of being ethical. Scope of practice. Helpers should only use methods they are trained for. If someone's needs are beyond your expertise, it's ethical to refer them to another professional. Ethical trauma work means doing no harm, respecting boundaries, and ensuring that practices support healing rather than causing more distress. As we wrap up Chapter 2, let's bring all the components together. Trauma is more than a story of what happened. It's about how the nervous system responds when overwhelmed. Survival responses can get stuck, leaving the body dysregulated. We distinguished stress, trauma, and PTSD, recognizing that trauma symptoms are biological, not personal failures, and dysregulation can exist with or without a clinical diagnosis. Milacaris reminds us of the different trauma categories: acute, chronic, complex, developmental, and the heuristic of big T and small t, while emphasizing that impact matters more than labels. The autonomic nervous system plays a central role. High zone, fight flight; low zone, shut down; and the resilient zone, balance. Our goal is to expand and return to that resilient state. Context and culture shape how trauma is experienced and how healing happens. Risk and protective factors interact to influence resilience, which is not fixed, but a capacity that can grow. Finally, trauma-informed work carries ethical and practical responsibilities, prioritizing safety, pacing, informed consent, and working within our scope of practice. When dealing with trauma, remember it is a biological and contextual experience, not a character flaw. With awareness, community support, and resiliency skills, people can move toward healing and balance. Please be sure to read the chapter and complete your assignment by the deadline. Remember to use APA formatting and include citations when discussing the work of others. Thanks for listening.